Hi, Deb Williams. I'm an old Washington hack here to talk with you today about market consolidation. Now, our last panel was talking a lot about pharmaceuticals, so we're going to concentrate, I think, much more on plans and brick and mortar industries, but we might spill over into that industry. So, what we got here today? I mean, this is a hot topic. I'm telling you, we've got the President of the United States. He has a platform out there. Senate Finance had a large hearing on this topic in June. We've got the FTC is meeting as we speak. The FTC is meeting to workshop the draft guidelines, which will take a new look at how you can do mergers in America. So that's what we're going to be talking about, something that is so hot that when you go in for your job interviews, if you go in for your job interviews this summer and fall, you'll sound much more au courant, which is good, as opposed to being a gaping idiot. But so I think that's good. So I'm Deb Williams, and you guys want to briefly introduce yourselves?
Hi, is this on? I'm Valerie Lewis. I'm a professor in health policy and management, and my work looks a lot at value-based payment deliveries and healthcare reform models that are often associated with consolidation, or we see consolidation happening in the market. I also study healthcare providers and healthcare systems and how to best arrange, or how we might best set up healthcare systems and providers to deliver high quality, high value, low cost care in the US.
Good morning, everyone. My name is Stephen Harris, Keenan Flagler, MBA 98. Pleasure to be here this morning. I'm the president of Blue Cross and Blue Shield of Illinois. We serve 9 million members across the country, primarily in the state of Illinois, but we represent 28 of the 35 Fortune 500 companies in Illinois are Blue Cross card-carrying members that are national and international. My responsibilities include managing our customer accounts, so sales and account management, medical management for our fully insured and custom accounts, and then network management. So that's managing the relationship with all of our major hospital systems, independent providers, provider groups, ancillary providers across the state of Illinois. And then other responsibilities for legislative relations, communications, and market strategy. So again, pleasure to be here this morning.
Hi, everyone. I'm David Keys, and I'm the Chief Development Officer of Acadia Healthcare, which is the largest pure play, independent, publicly traded behavioral health company in the country. But I'm here as a graduate of the 95 class of Carolina undergrad, where I was a poet, poli-sci French, not business. And I've been blessed to have a great career on all sides of the table within healthcare over the last 20 years. So private equity, entrepreneur, investment banker, and now chief development officer of a publicly traded company. So I give a caveat up front that a lot of my commentary is really based on that 20 years experience, not just through the lens of Acadia. I'm not a mouthpiece for Acadia here today. And I think it's going to be relevant as we go through some of the topics on competition, consolidation, and the rationale for it. So thanks for having me here, and I look forward to hopefully providing some thoughts on my experience.
Okay, so to level set the audience, in case you've not spent much time studying this area, I'd like to ask my panelists, maybe each can go in turn if they want, to discuss what they think, how they view the players, and define what is vertical and horizontal integration. What are we really talking about here when we talk about concentration? Concentration of what?
I'll start with the hospital side. And again, I work for a behavioral health company, so not med-surg. And typically when you're looking at the research around consolidation, it's typically focused on medical surgical hospitals. That's where most people's experience is. Behavioral health is a subset of the healthcare industry, highly, highly fragmented. Acadia only has about 4% market share. Our largest competitor has about 10% market share. And it's a market where the addressable market is actually about 35% underbedded. So there's a lot of just organic growth within that space. And one of the things we'll talk about today is the importance of access. So in terms of consolidation for us, it's rarely vertical, meaning, going down to the provider side. It's typically horizontal because we're trying to bring access to new geographies, new markets. So looking to acquire other hospitals in other markets just to have broader presence within the overall marketplace. And we'll talk more about, why that is necessary for efficiencies and scale benefits.
Yeah, I can address that from a payer perspective. When I think about horizontal integration, it's really payers acquiring other payers. And that has happened quite a bit over the last 10 to 15 years. And most of it has been around seizing on opportunities to grow geographically and looking for opportunities to grow and expand their business models in areas where the population will or has seen significant growth. And when I say that, I'm specifically referring to the Medicare population. And so if you think about a lot of the horizontal acquisitions that have taken place that are noticeable over the last 10 years, I think about AmeriGroup and Anthem, which gave them an opportunity to expand their presence in the government space, particularly Medicare Advantage special needs plans in a dual eligible population. Additionally, I think about the WellCare acquisition by Centene, which allowed Centene to significantly expand its presence in the Medicare Advantage space. Those opportunities really gave the acquiring entities an opportunity to look for growth opportunities, where today what we're seeing is pretty much stagnant growth in the commercial space. So most of the growth activity in the payer market or across the industry has really been in the Medicare domain. Similarly, when we talk about and think about vertical integration, it really has centered around opportunities to really add additional capabilities to serve and build margin around certain product offerings, Medicare being primary. So if you think about some of the transactions that are noticeable over the last several years, we talked in our last session around the PBM tie-ups between Express Scripts and Cigna, CVS and Aetna. This has really given the payers as well as the PBMs the opportunity to really extend their reach in the Medicare space with older Americans that typically have more scripts. And so that is what we see in the vertical space. That also extends into behavioral health, where a lot of the PHOs that existed several years ago have been acquired by payers. And most recently, there have been acquisitions in areas such as physicians, such as Signify being one recent acquisition, and Oak Street, that have allowed payers to also extend their reach in a direct delivery space that allows them to, again, better touch and better serve their Medicare members and provide margin opportunity.
So I think I'll round this out with kind of the more healthcare provider space, where horizontal integration in that space looks a lot like, I usually say healthcare used to be kind of a mom and pop or a cottage industry where physicians kind of set up shop, practice on their own. And now we see, of course, that a lot of those small practices are merging or getting purchased by either larger practices, so larger medical groups, which would be a horizontal integration, or those physician practices and medical groups being purchased or merging with large healthcare systems. So if you think in our state, for example, UNC Health is expanding its reach across the state through both vertical and horizontal integration. I think, UNC acquired the Rex hospitals in Raleigh as an example. In the western part of our state, the main health system and hospital there, Mission Health, was recently acquired by HCA, which is a large national hospital chain that includes hundreds of hospitals around the country. And similar, we do see payers purchasing or acquiring physician practices. I think Optum, owned by United, is another big one, of course, that owns tens of thousands of physicians around the country now, or physician practices around the country. We also see the other direction of providers moving into the plan space, which is another kind of direction of vertical integration, where providers will start their own health plan and sometimes that starts for a small population. Sometimes that's trying to be a larger population. I think that was a little more on the radar maybe 5 years ago and a little less on the radar now, but still another kind of direction that these horizontal vertical integrations go. And I think if a lot of things are also happening kind of under the radar of a lot of people. And if we think of all of the other domains of healthcare or services in healthcare that are delivered, like the PBMs, I think there are nursing homes, for example, and skilled nursing facilities and integration happening with those. There's kind of standalone care management companies or tech companies that have stood up apps or data apps that are being used by healthcare providers. And those companies are starting to look, the mergers of those kinds of technologies or those other kinds of services in with the big healthcare systems or the payers or what that looks like. I think there's a lot on the horizon with that, and being attuned to that is kind of the next direction we'll see the vertical integration start moving.
So what I heard David say is that behavioral health is a little bit different than, say, acute care hospitals. Only about half of physicians today are actually employed by physician practices. The other half are by hospitals or by investor joint ventures of some kind. So that's an interesting difference, I think. And also, David, you were talking about, essentially, for example, is it Illinois and Vermont became, why anyone would want Vermont, I don't know, but became, are entering into an arrangement, or was that Indiana? Michigan and Vermont were entering into relationship. But we also see, for example, plans buying, like, is it Oak Street and other things. So there's quite a bit of variation. So is there a reason for why things are different, or a reason for why things are the same?
Well, so I'm going to go back to this morning's panel as well, just to reference the complexity that exists within the healthcare system. So I'm not going to speak to the plan side of it, but I'll talk about it within behavioral health. Oftentimes I'm asked, why aren't we actively targeting vertical integration and bringing in providers directly and acquiring those providers? Believe it or not, it's referrals, right? Many times we'd be stepping on the toes of the referrals to us at Acadia if we were acquiring those providers. So it's just one of those levels of complexity that people don't think about. They don't think about the referral dynamic. They just think, wouldn't you be better off if you control that unit of production, i.e. the provider themselves? And no, there's always other considerations.
Yeah. So as it relates to, the plan perspective, I think it has ebbed and flowed over a period of time as it relates to horizontal versus vertical. I think we are about to enter into a new wave of horizontal consolidation, as referenced by the Michigan, Vermont tie-up with the Blues. I think there'll be, over the next several years, more Blues tie-ups. And one of the drivers for that centers around overall competitiveness and the need to gain scale to be price competitive with large national accounts relative to our competitors. So you think about a United Healthcare or Aetna, which have national reach. They are tightly integrated, with their PBM. They own physician relationships. So in order for some of the traditional smaller regional players to compete, they have to have the scale so they can make the necessary investments in technology. Another driver is regulatory requirements that also require significant investment dollars to make it increasingly difficult for smaller regional players to really thrive and operate. You think about the margin opportunity for a smaller regional player, particularly a Blues, you're talking somewhere around anywhere between 1-2% margin, if that. And so to have the necessary excess reserves to make investments in regulations such as network adequacy and transparency related requirements, or otherwise, or other system enhancements to enable AI technologies and the innovation that's on the horizon as it relates to that, requires a partner. in many instances. So I think that is one of the other drivers that we will begin to see more consolidation horizontally over the next few years or so.
And I'll also speak a little bit to the behavioral health, which I think is unique in part because it's been so under-resourced and under-reimbursed as a service. And some of that, I mean, the ACA put in a little bit more help with that. But it's one of the areas where, for example, we actually see cases of de-integration where, for example, large healthcare systems do the math on what their reimbursements are for behavioral health and realize that the reimbursements they're getting with private insurance can't really cover the cost of that. So they will sort of spin off their behavioral health providers into their own little organization so that they can bill out of network to meet their costs. And I think that creates a different set of dynamics in terms of why you would integrate or not, or why you would make decisions when you have something that's historically been undervalued and underpaid for, and what you need to do to solve those problems.
Yeah, that's a great point, and something folks may not be aware of. In 2007, mental health parity laws came out. They still haven't been fully enforced, right? So mental health is not reimbursed in an aggregate to the same degree that medical surgical procedures are. We were also left out of the High Tech Act, so we didn't get the funding for HCIT investments that medical surgical hospitals did. So I think back to this morning's panel and Francis's comments about trying to move forward with technology when you're based on 1970s mainframe businesses. Well, within behavioral health, it's really tough because outcomes are incredibly important. And in order to move towards value-based care, you have to prove the outcomes. Well, to prove the outcomes, you have to track the data. If you can't afford to implement those tech systems, you can't do it. And so that's a driver of a lot of the inbound interest in consolidation. So it's not always the big acquirer seeking to bring people in. Oftentimes, it's the grassroots, smaller provider looking to join up with the larger provider because they can't bear the administrative costs and they can't bear the investments in technology.
I think that extends into the larger provider space outside of behavioral health as well, where value-based care has really driven quite a bit of change, I would say, over the last 5 to 10 years. I think we have a long ways to go as it relates to value-based care. But I think what we're seeing is the more sophisticated hospital systems that have the capabilities to take and manage risk are becoming stronger in the market. And the ones that have been averse to taking risk and averse to making the necessary investments to support value-based care are finding themselves in a difficult circumstance as we move forward, and they are often in the position of having to look for a partner that can help them. And the hospital systems that and oftentimes do have the strength are those that have provider-sponsored health plans. And so as we look at acquiring entities, those that often have the provider-sponsored health plans are the ones that show more strength because they have the capabilities. They understand, the back office infrastructure and how to manage risk on a cohort basis from an actuarial perspective, and know how to win at that. So, I think that's another thing that we're seeing on the hospital side.
Okay, let's step up the attention a little bit here. I said the president was very concerned about healthcare consolidation, particularly its potential to raise prices. So the Health and Human Services Department, and within that is a group called the Assistant Secretary for Planning and Evaluation, ASPE. You can Google that. They've done a couple reports on hospital consolidation. First one was in 2022. And basically it said that hospital consolidation raised prices. That means costs to employers and health plans, and with the average health plan being about the price of a mid-sized Toyota. That's important. So what does this really mean? Does the hospital consolidation raising prices mean for access and quality? Do you want to take that on, Valerie?
Yeah, so consolidation raises prices. The evidence on how much it affects access and quality I think the most charitable read of it is mixed I think the promise of consolidation is always held out as this will achieve efficiencies that at the end of the day are better for the patients. So we will either get the technology in place or be able to invest in new programming or through any other number of mechanisms of essentially the pooled resources, be able to invest in ways that at the end of the day will get down to better care for our patients, whatnot. We see that it raises prices. And the research, at best, there's a few minor outcomes on which we might see that consolidation leads to improvements in either quality or access. But overall, we generally see no change. So consolidation doesn't improve quality as far as we can measure it in data at the patient level. It does. The consolidation does seem to often help retain providers. And so big health systems are able to employ and pay providers. And I think, again, the pooled resources and capital available kind of allows for a steadier way to employ maybe high quality providers. And that said, we also have a lot of concerns about physician burnout. And when we talk to physicians employed in these large systems, you can kind of see the difference of the revealed preferences and the stated preferences where they are choosing to work in these big health systems and they themselves have a lot of frustrations about what their job is like, what autonomy they have versus what their employer has. So I think it's always held out as a promise of better quality and better access, at least in the vertical consolidation of like hospitals acquiring providers and the coordination that'll imply. But so far, we haven't really seen those benefits realized. And we actually see that, in the value-based care space, it's providers that aren't vertically integrated with hospitals. It's kind of outpatient medical groups without a hospital that are best able to improve quality for their patients, reduce unnecessary hospital use for their patients, improve kind of same-day access to care. So I think you have really interesting tensions over the different forces providers are facing and what they're responding to in that sense.
Yeah, I think that the healthcare delivery system has gone through quite a bit of a transformation, a remarkable transformation over the last 10 to 15 years, where there's been a lot of innovation. And the innovation has resulted in a reduction in inpatient stays overall, where a lot of procedures can be performed on an outpatient basis that traditionally in the past were performed in an inpatient setting. And I think that has put a lot of the large hospital systems at risk of protecting their margin position. So as a result, they have gone and they've looked for ways to extend their business model into the outpatient setting, which has driven quite a bit of vertical integration. So hospital systems expanding and acquiring physicians allows them to extend their reach and their referrals, not only to capture outpatients, but their referral into their mothership, their traditional hospital setting, which is fine. I think that's, that's business minded. It allows them to, at least the stronger hospital systems, to preserve and extend their brand out into the community in a way that they haven't traditionally been able to do. And it allows them to compete with payers that have also acquired physicians that have been able to successfully navigate out of the inpatient setting and preserve margins for their shareholders. Also a win is, to the extent that from a consumerism standpoint, I think the hospitals that have stronger brands are those that have been acquiring entities that have been able to extend their reach farther into communities. But the challenge with that, as it relates to the increase in prices, is in a lot of instances, those tend to be your academic research medical institutions, which tend to operate at a higher price point than your community hospitals. And so while the brand is stronger and the health system tends to have more access to research, and has access to top performing physicians that are recognized in that way, it does add cost to the system. And I've never seen a situation where I've seen an acquiring entity or consolidating health systems result in lower prices. And given that there's lack of transparency overall, there's no clear indication as to whether or not the acquiring entity is actually delivering better quality. It's better name recognition and better perceived quality, but it's unknown whether or not, or we haven't seen quantifiable evidence that it results in better quality outcomes. So I think that's one of the challenges that we're faced with as we deal with consolidation. The other instance is we see instances of site of care anomalies, where as hospitals move to acquire physicians, there are changes in billing practices where physician services that may have been charged at an office visit setting are being charged at an outpatient level, which automatically drives an increase to the end user, sometimes by 2 to 3 times of what it was pre-acquisition. We also see that hospital systems tend to route their ancillary services internally through their hospital system, whereas pre-acquisition, the small physician group was able to have relationships with a lower cost option. So we see that with lab. If a acquiring health system has their own lab, they acquire physicians, send the volume through their lab at a higher cost, which results in higher costs for the end user. That also applies to DME. So while we see some benefits from a consumerism standpoint and from a brand perspective where folks have perceived quality, there is a cost associated with it.
Yeah, I think, Stephen, you said some very important things I want you to hold. And if you guys go and you graduate and say maybe you go to HHS or you apply for the presidential management internship, and then you think about these issues, which is one is often not talked about is how technology itself can drive integration. For example, one of the reasons that Medicare costs per beneficiary are going down, unlike the New York Times, which can't Google the trustees report, are because knees replacements are now done outpatient, not inpatient. But you also see, and you can check, for example, my Health Affairs blog piece from a couple of weeks ago, talking about the problem of the site of service. You go into the doctor's office one day, and it's, you're paying the doctor. You go in the doctor's office the next week, and there's a little sign purchased by XYZ hospital, and you're paying 2 fees, one to the facility and one to the physician, and that cost is higher. So, but the takeaway, and we'll get to this at the end, if you're thinking about it from a regulatory point of view, is how do I measure the outcomes that matter? Cost, price, and quality, as if Valerie was saying, I really don't know how to measure quality well. And we'll talk about that at the end when we get to federal and state. So let's talk a little bit. Now we're going to put the pressure a little bit on Stephen, which is what the heck, he can take it, I think, don't you think? Which is the same brand report found that insurer consolidation increases premiums. And you talked in detail about why plans consolidate. Are you able to reduce provider prices? They found mixed evidence, but and talk about one of the problems with, and Valerie, anybody can chip in, with the impetus to address the big hospital systems through plan consolidation and whether you really can reduce prices for consumers and how can you measure that?
Sure. So, our goal is to bend the cost curve over time. And so we do that by, managing our trend relative to inflation. And we have collaborative relationships with our large hospital systems. And so we work with them on negotiated rates, and equally important is to maintain access. And so we're known as being the provider that we're here when you need us. So we have access and coverage to all 102 counties with all of the major hospital systems in Illinois. So that is who we are, which may differ from some of our competitors that may have narrower networks, and therefore have different negotiating tactics with their providers. So one thing is managing the relationships, making sure we have access and balancing that against negotiating and getting, lower rates or the lowest rates. But that's something that we engage in all day, every day. And sometimes that results in provider disruption, which is something we like to minimize, because that's not a win for anyone when we can't reach agreeable terms with a provider that results in disruption for a member who can't get the care that they need, and they're forced to drive to another provider that may be 20 miles away, or forced to change their relationship or pay more out-of-pocket costs. And so that's not a good outcome for us. And I've experienced those circumstances, currently working through one of those situations. And that is a challenge that we have to work through. I will say, in addition to that, we make heavy investments in care management. So making sure that our members are getting the right care and we're navigating them through the process if they have a critical need. So we have a team of RNs that serve as care managers. So whether it's a incidence of cancer or COPD or cholesterol management, we're working with the member to make sure that they understand their treatment protocol, that they're adhering to their medication adherence protocols, and that they're doing the appropriate follow-ups and have an ongoing relationship with their primary care physician. Mm-hmm. We believe all of those things over time allow us to bend the cost curve, and we do that in a way that we can manage and maintain a good relationship with our physician partners. Fraud, waste, and abuse is also important. And so we make heavy investments in fraud, waste, and abuse, and monitoring certain services that we believe to be abusive within our provider community, and calling those out. And so from time to time, we will actively manage and actively engage with providers that we believe are providing medically unnecessary care. And there are several examples that I could go into, but that is an ongoing area where we believe that we add value and lower costs over time.
So Valerie, how do you get at the area, this issue of having a secure, large network with no disruptions and being able to lower prices at the same time? How would you approach that? Is there any research on that?
I'm not familiar with research. That we'd all, if we knew, we would.
If we knew, we would know, right?
I do think, as Stephen was talking, I was reflecting on. Stefan was talking. What I was reflecting on was the challenge of I think there's trade-offs. So when you have a a more consolidated payer market, in some ways that's a lot easier for providers because they're interacting with fewer payers, which is less administrative burden for them. And we also hear that in a lot of cases, they can develop this more deep partnership where they feel like the plan is a partner and they can, come up with a shared vision or some shared goals and pursue those. And when you have a much more competitive payer market, providers are dealing with a lot more payers, which is kind of more work for them, as well as kind of dilutes those sort of relationships that they might be able to form with the plans to pursue goals together, and kind of can dilute the ability to try even new payment models, new strategies to reduce costs. So for example, here in North Carolina, Blue Cross is a dominant private payer and pursued very aggressively a plan toward value-based payment and was able to drive that a lot in the state. And versus some other markets where you see a lot greater plan competition, which is good for some reasons in terms of, I think providers having options of who they're going to work with, being able to work, be more selective. And you hear that providers in those markets have a much more difficult time often kind of pursuing innovations they might want to pursue in terms of alternative payment arrangements, partnerships with plans, investments in things like care management that plans might value that they could work on together. So I think it's a real tension. And I think the research has largely examined this more either from the provider side or some overall high level quantitative analysis on the payer side, and has not really kind of gotten into that black box or looked at that trade-off or that equilibrium between provider consolidation and plan consolidation. And I think we probably don't want to head toward the complete Amazonification of healthcare, where we have like a dominant payer and a dominant provider, and we're all subject to what they're doing. But you know, where we land in the payer and provider consolidation, I don't think we have good data on what's the optimal balance.
You know, Valerie, your comment about, you know, the providers trying to build relationships with the payers. I'd put that in the bucket also of sort of an administrative burden to them, right? Like operationally, they're having to develop those relationships. If they don't have the expertise in doing that, that's takes a lot of time and energy. Then Stefan, your comments about bending the cost curve, I think about it from the behavioral perspective, you know, comorbidities. You know, about a fifth of the American population has a mental health or behavioral health issue. About a sixth of the population has substance use disorder issues. And so you relate that to the comorbidities on the medical side that can be, you know, created by having a behavioral health issue or substance use issue. That's not bending the cost curve, right? That's adding to the costs. We actually seek, well, first of all, about 53% of our payments come from Medicaid. So we're kind of a price taker in that category. But we actually seek to be in network in our markets because we want the relationships with the payers and creating that partnership to try eventually to prove the value. Again, circling back to the lack of IT and the inability to really truly track outcomes right now. But that's, you know, what we're moving towards. And I think it benefits the aggregate spend in the marketplace. So overall, over time, hopefully it will bend the cost curve by addressing those co-occurring conditions that drive greater costs.
Yeah. Is it time for us to open for questions? Okay. We're going to open for questions, and then we're going to come back and talk about federal and state efforts to deal with this regulation, deal with the very real problem that most hospital markets in America today are concentrated. And you know, 3 big PBMs control, you know, 85% of the market, et cetera. So I'll open up, and do we have any questions in the audience? Yes, sir.
So do you think this consolidation is going to continue in the for-profit area in healthcare? Or do you think we'll have any type of rollback to the early days of Blue Cross Blue Shield, when they were basically a tiebreaker between the providers and the employers, and they were non-for-profit? When things seem to work a little better there, you're much happier as a physician. And I understand all the things that have gone on to make the industry consolidate. So the legal ramifications of forcing every doctor to put 50 grand per doctor into an electronic medical record has been, as far as I'm concerned, disastrous to the independent primary care physician market. So now we have these gigantic payers and gigantic health systems across the country, and you're saying that there's been no real cost savings in doing it. It's unbelievable.
I agree. It is unbelievable in terms of the regulatory burden that we've had to deal with over the last 15 years. There are probably some intangible benefits. I mean, even if you think about, electronic medical records and what that has done to allow individuals to have access to their medical history in a way that they could not. I can open up my phone right now and open up my chart and see my history going back to 2010, over 3 different hospital systems in 3 different states. So that allows me better line of sight into my own care. And it becomes portable for me as I begin a new physician relationship if I have to relocate. So, there are some benefits. So I don't want that to go unnoticed. And with that, the same applies to, the Transparency Act that I mentioned earlier. Significant investment from the payer side. But I think that's necessary in order for us to get to where we ultimately need to be. So if we're going to see some improvement in the long run, I think that we need to advance transparency across the board, whether that's through the earlier discussion that we talked about as it relates to pharmacy and the treatment of rebates, spread pricing, and all of the other, middle handoffs in between, or in the payer space and provider space as it relates to the actual cost for and price for a particular procedure and the associated quality equaling the value that a person will get in a way that's simple and easy to understand. as it relates to consolidation, I don't think we're there yet. As I mentioned earlier, as it relates to horizontal, particularly with the blues, I think there will be more blues consolidation on the horizon. And, this year was probably the start of it, where we saw the Anthem proposed tie-up with Blue Cross and Blue Shield of Louisiana that was postponed, or it's now in a tolling, format. And then the Blue Cross and Blue Shield of Michigan and Vermont tie-up. Now, part of that is driven by litigation. And yeah,
What I'm saying is that I've worked with Blue Cross Blue Shield of Virginia for 5 years. I've built all the disease management systems, all electronic interfaces between providers and employers. And Anthem is just a gigantic thing out there. And the doctors think it's a thing. Nobody has any real relationship with it. They shouldn't continue to consolidate. I mean, we have a real problem, and nobody wants to go into medicine as a physician because it's a machine.
Okay.
Not at all beneficial as a career to a lot of people in healthcare.
Yeah.
We've got a real problem in this country, and I agree that I can get access to 6 medical records, but the problem with your industry is you don't share them and you
Okay.
don't roll them up in a nice way that is simple, like in the banking world where people can get APIs from all their different systems and then have a catcher's mitt of this is my medical record, because the health systems all keep it to themselves.
Okay.
The payers have it, and the providers have it, and the physicians have it.
Okay, thank you for our comments. We'll see if there's any time left over for one more question, because I knew you had one in the back, but I wanted to get to our last question because your question was very well taken. Is this consolidation going to stop? And I talked about how the FTC was meeting today to have their workshop on their draft principles for guidelines. There's also states have processes, and it's a process that's done by NASHP, which creates an administrative notice review and approval process. Do we really think there's going to be any teeth to these models? What are the pros and cons? What's going to be the outcome of some of these efforts at a federal level or state level? Go ahead, say anything you believe.
Well, all right, I don't think I'm sitting on a soapbox, so I'll try and not go on for too long. But I mean, I will speak personally, again, outside of Acadia. They cause me great concern, right? I went to the University of Chicago. I'm a free markets capitalist by nature. I don't love when regulation from the top down puts constraints on the ability for entrepreneurs to seek to grow their organizations, to partner with other organizations. And I think there's really 3 levels to it. There's federal, so you have FTC. There's state, where you have certificate of needs laws or regulations that impact whether you can build a new facility or sometimes whether you can acquire and the transfer during an acquisition. But here's where I am on my soapbox. Really, it comes down to us as individuals and what we want, because the local is really the biggest constraint. And what I mean by that, and you'll see this in a lot of articles, is NIMBYism, not in my backyard. So again, I go back to the prevalence of demand for mental health care services. We all need it. 1 in 5, 20% of the population, yet nobody wants it in their community. The level of zoning and regulation rules about what you can actually build in your community are a huge stumbling block. It's always the next community over. Build your hospital 3 counties over. Put it, don't come up with a substance use facility in my community. Put it in the next one over. So that's really my greatest concern, because I think the reality is, while FTC has rolled back to their 2010 benchmarks for HHI, which is scary, I do think that's a cost of doing business. Like, you can incorporate it in your M&A strategy to evaluate, okay, how much are we going to have to spend to actually prove that this consolidation is worthwhile to the marketplace? You can deal with that. The NIMBYism, though, is much, much harder because it's a grassroots effort and it's really hard to break through. So I'll get off now.
And last 2 comments from the panelists, because I think we're coming up to time.
Yeah, so just quickly, I think that there should be additional funding for the FTC to, not only investigate mergers, potential mergers, but also anti-competitive behaviors that may occur post-merger or pre-merger. And so having some additional dollars to investigate those, particularly those all or nothing negotiating parameters that sometimes hospital systems use to, increase prices along the way, I think warrant some additional attention. On the state level, I think the certificate of need process on a state by state basis should be reviewed. Often it's politicized and doesn't necessarily get at the root of what could be driving anti-competitive behaviors in a particular market. And then lastly, I think you touched on Medicaid and Medicaid funding. I spent quite a bit of time, a big portion of my career working in Medicaid managed care. And I think if there's one potential solution that could improve the overall healthcare delivery system, particularly for commercial payers, it's an increase in Medicaid funding, where, commercial payers are subsidizing the cost of Medicaid across many markets. And it becomes a challenge for rural hospital systems and urban core hospitals. And that is it presents an issue from a pricing standpoint, and it presents an issue from an access and delivery and health equity standpoint in many of our markets.
And the final comment I'll make is, I think the FTC is one mechanism, but the other kinds of mechanisms we might think about are other kinds of decisions that policymakers or purchasers are putting in place. So for example, like the HITECH Act or policies kind of pushing us towards value-based payment. A lot of those, whether or not they intend to, often reward organizations or make it a lot easier for organizations that have a lot of capital and have a lot of resources to bring. So when we think about kind of policymakers designing policies and the unintended consequences of those policies and kind of what kind of tailwinds those are putting on a market that's already consolidating and thinking through ways to build in tracks or build in ways of smaller organizations still being viable in the marketplace, be those smaller plans, smaller provider groups. I think, North Carolina transitioned from fee-for-service Medicaid to managed care Medicaid and had a solicitation for plans. How those plans were chosen kind of resulted in what plans are in place. And I think those are points where policymakers or regulators are making decisions and putting policies into place that can also kind of pour unintentionally fuel on the fire of consolidation, where we might be wanting to pay more attention and think about what the downstream effects are on consolidation.
So this is true. I have to say that our panel, what you heard today, is probably one of the most important things for you to hear today, because among other things, this is not 2009. This is post ACA. And anything that drives up employer costs has to be paid for by the federal government. The federal budget deficit hit $2 trillion this last quarter. And if you spend any time, and I hope as business students you do, reading the Financial Times or in the Wall Street Journal, you know that the deficit is one of those things that may tip us over into a recession. When you think about the value of our debt, let alone servicing the interest we must pay on it. So if we don't address these problems, then how are we going to address the debt, and how are we going to stave off a deep and lasting recession? Thank you.